Thank you so much for the generous introduction. And today I will be focusing on the perioperative neurocognitive disorders and risk mitigation. My research is supported by NIH, Philanthropy, and also Massimo Inc. And I come from Beth Israel Dickness Medical Center. You see the East Campus here and then the West Campus, now currently called as the Shapiro Building and the Rosenberg Building here. And you can see the Fenway Park right on top. It's very common in Boston. I'm just going to jump right into this. Now, we're going to follow a certain outline. What is a perioperative neurocognitive disorder? Why do we care? What can we do about it? Intervention opportunities in the postoperative period, especially focusing on pain and sparing the opioids. Can we do something about their sleep? And in the intraoperative period, can we do something about the anesthetic we receive? And in the preoperative period, can we do prehabilitation, specifically for cognitive training, using meditation and techniques like lumosity, right? So, what is a perioperative neurocognitive disorder? A bunch of experts got together and then termed this as perioperative neurocognitive disorder. This was published in anesthesiology and many other journals. So cognitive decline diagnosed in the preoperative period will be called as NCD. In the hospital up to 1 week post-procedure, which will be called, or until discharge, we'll call that as postoperative delirium, right? And 30 days after the procedure, that is delayed neurocognitive recovery. In 30 days and 1 year postoperatively, we'll call it as mild or major NCDs. Why do we care, right? So when you look at these, anybody who had a postoperative delirium, and you can see that these dashed lines are those who had delirium and the continuous lines are those who did not have delirium, they take a major dip. Both of them do, but those who had delirium take even much more of a major dip in their cognitive performance, and it kind of comes back, but it stays down. You can say about 12 to 36 months after surgery. So it seems like not only short-term, but this is a long-term issue. Let's say we adjust for their baseline scores, right? In their, it seems like it's the same story. And the duration of delirium, again, it's the same story. It seems like there is a long-term problem that is associated with the postoperative delirium in these patients. Is it just postoperative cognitive decline? Can it also lead to dementia? So this work from Liz Everett in anesthesiology talks about prevalence of dementia. Up to 7.5 years after CABG, you can see that the red bars, which are after CABG, and the blue bars is the general population prevalence. It seems like it is a pretty long, the incidence is pretty significant. Now, in the right-hand side, you can see the adjusted, Cox proportional hazard curves. And again, it sees that the red line, which is those people who had a postoperative cognitive decline, and you can see that it just goes down and down compared to those who did not. What can we do about it? Now, in order to do that, we have to know the mechanisms for this. So you can see that there's a tau, which is an integral component of neuronal microtubules, and the tau levels goes up, comes down at 24 hours and goes down. So you can see that tau is probably an important central neural injury component, which increases. And neurofilament light is a sensitive marker for axonal injury, and it goes up and stays up for almost 48 hours. So there seems to be some central neuroinflammatory markers that seems to increase with surgery. So now let's just go on to the next slide. You can see that again, this work from Subramanian and Nick Torando from Duke have shown elegantly the neuroinflammation that could happen in these patients. So you can see surgical trauma goes in the blood and releases all these markers such as TNF, tumor necrosis factor, IL-1, IL-6, and the blood-brain barrier integrity is lost in the surgery or somewhat compromised, and then can just get into the brain and lead to central neuroinflammation. So that is a theory which has been proposed in these patients, right? And low-grade neuroinflammation, microglial activation, blood-brain barrier disruption, A1-like astrocytes, seen also in aged POCD models. So mechanisms and risk factors. So we again go through this. It's and anesthesia. Can anesthesia itself, general anesthesia versus regional anesthesia, can it be a modifiable factor? And age, something that we cannot modify. And we all know that from many studies, advanced age is an important predisposing factor for post-op cognitive decline. And pre-existing cognitive impairment. We have been talking about doing baseline cognitive tests. Even a simple test like a mini-cog should be done, but majority of the cases we still don't do it. Something very important that we should start doing it in our patients. Alcohol abuse, low educational status, and genetic factors are the features. Now, recently we published a review in anesthesiology in 2021 December. We talked about sleep, pain, and cognition as 3 modifiable targets for optimal perioperative health. So let's just delve deep into that. Acute postoperative pain, let's just take the example of cardiac surgery, mainly because cardiac surgical patients are at a very high risk for postoperative delirium, as much as 30 to 40% of them. And moderate to severe pain is experienced over 80% of patients. Majority of the pain control in these patients are still not optimal, and it is nurse-controlled analgesia, and they get the opioids as a main factor. We had published some data on preemptive analgesia way back in the 90s. And it's very hard to do human studies because it's very hard to have a control group where you don't give any analgesia at all. But elegantly shown by Clifford Wolf and his group in animal studies. So it's a real concept. So preemptive analgesia evolved into preventive analgesia with multimodal analgesics. And now with more and more awareness about opioid-sparing pharmacology, using IV acetaminophen and sternal block techniques. And probably we can also use some amount of meditation to reduce postoperative pain in the form of rehabilitation, provided we have some time for that, right? It's also important to know what is pain perception and what is the patient's requirement. Sometimes you can have pain, but you may not need more. So there is difference between what you perceive and what you ask for. This pain model was published in early 2000s from Brigham, and it's a pretty good model. It talks about the injury that happens during the surgery actually persists for almost 72 hours after the surgery is done. So if you don't give any nerve block, it seems like there's persistent inflammation throughout, how much ever you try to combat it with analgesic drugs and other forms of stress reducers. But if you do give a short pre-injury block, seems like this whole process is slightly postponed. If you give a long pre-injury block before the surgery using this preemptive analgesic concept and reduction in the CFOS memory, probably there's a potential theoretical model that you can probably avoid this entire pain hypersensitivity throughout the surgery. If you do it in the post-operative period for a short period, you can avoid that. But if you're a long block, probably you can avoid from the time you give the block on. So this model is actually pretty good. So with that, we've been trying to do a few things in our own surgical patients. As you know, cardiac patients are not easy to block. So we used a simple block called pecto-intercostal facial block that can be done after patient is anesthetized. And it's a very superficial block. You can see that in the cross-section of the ribs. And then here comes the needle. And you can basically go right under the pectoralis major and right above the intercostal muscles. It is like a tab block, only that it happens in the chest. Was it any effective? It seems like none of these blocks can actually produce complete prevention, but they act as good adjuncts, especially when it is used as a rescue block. So more to come, but this particular study showed that it's a good rescue block, but probably we need a larger sample size and probably we needed to do something in the post-operative period to sustain this efficacy. Way back in 2004, we did a ketamine review and we showed that short, smaller doses of ketamine infusions throughout the surgery actually acts as a pretty good protection against long pain, like even after surgery, and I'm talking chronic pain, can be useful for patients with resistant pain, such as opioid tolerant patients, etc. So ketamine is a good analgesic adjuvant because it also acts through a different mechanism, that is NMDA receptor antagonism. Now, IV acetaminophen, we are very fond of that. We published a few articles. We think it has opioid-sparing effects, analgesic effects, and possibly central anti-inflammation. It's not technically considered as an anti-inflammatory drug, but if it is given the right doses and if it crosses blood-brain barrier, maybe it can confer central analgesic properties. There is a probable mechanism. There is AM404 is a novel metabolite in the of acetaminophen in the nervous system, and it can provide a link between acetaminophen and the cannabinoid vanilloid receptor system. So in our 120 patients we published in JAMA, we showed a significant reduction if you give IV acetaminophen at 6-hourly intervals for 48 hours. Remember the preemptive analgesia concept and also the analgesia injury concept that I showed you probably tackles the injury in the first 48 to 72 hours, the maximum period of injury, blood-brain disruption, and the central neuronal injuries. Maybe that is the mechanism by which it acts. Still to be elucidated how it actually provides this protection, right? So we also finished a study on guided meditation and trying to see whether it has helped the patients at least, lowering their expectations of having zero pain, and potentially that can avoid a lot of opioids. Now we are doing a multi-center IV acetaminophen trial with MGH, Brigham, Yale, UAB, UPMC, UCLA, Montefiore, and Leahy Clinic. And hopefully this study, which has a target of about 900 patients, we are 1/3 of the way through, can provide a definitive evidence for routine use of this drug. Even though this drug has become generic, people still are hesitant to use this drug routinely. So there's a risk of developing persistent opioid use, and you can see that it's pretty common in open thoracic surgery, cardiac surgery, thoracic surgery, etc., wherein you expect pretty high, significant amount of pain, and probably this is something we need to tackle. The highest risk after open thoracic is about 1.7%. Now let's just switch gears here and talk about anesthesia. Can we do something about anesthesia itself? And what does the literature show? Liz Everett again from Australia has shown that there's no relationship between general anesthesia or regional anesthesia and postoperative delirium and cognitive decline. At least in her retrospective study, this is not to be found. Similarly, Johns Hopkins group looked at a combination of 24 trials and did not find any relationship between the type of anesthetic and postoperative cognitive decline, currently called as PMD. What is the limitation of these perioperative neurocognitive decline studies? The problem is we do not know the rate of decline in the preoperative period because we see them at a cross-section. We do not measure what is the baseline, and we do not know the rate of their decline. Are we just capturing at a cross-section and then amplifying these natural processes? But as I showed in the first picture, there seems to be a dip in both patients who had delirium and patients who did not have delirium, only much more in patients with delirium. So there seems to be a real phenomena. But it'll be good to know the basal rate of cognitive decline. That can be a definite factor. It should come out of the population studies. Now, in the general anesthesia, so maybe we have to do a little bit more than just GA versus RA. So what we did was, this is a modification of total intravenous anesthesia. We also titrated to EEG targeting, not just EEG avoiding burst suppression, but looking at amplitude modulation as our N factor and using multimodal analgesics. So you use something for giving the sleep, which is an important component of anesthesia, right? So that is either propofol or inhalation agent. So here we chose propofol, and then we chose analgesics, which has secondary sleeping effects, right? So it is better to monitor something. And analgesics should act through multiple different pathways. It should act through NMDA receptor antagonism, opioid pathway is still the mainstay of analgesia, and also, using dexmedetomidine, which is an alpha-2 agonism, local anesthetics to block all the local effects, etc. And we also use some amount of magnesium even though it is routinely given for cardiac surgery patients at rewarming time. So now we use the SedLine monitor mainly because it gives multiple data points. It just gives raw data, it gives patient state index, and also it gives a density spectral array. So if all these three speak the same language, we're fairly confident the patient's really well anesthetized. And when we used that, we saw that our median duration of burst suppression was only 4.3 minutes, in contrast to some of the other studies published, like the Engages trial, wherein the median duration was about 8 minutes in the treatment group, and in the intervention, and in the control group is much more, like 12 to 14 minutes or so. If you do the multimodal anesthesia, you could bring it down to as much as 0.3 minutes. Whether these burst suppression avoidance actually translates into reduction of postoperative delirium is still to be studied. But how about just giving what they really require instead of just targeting on burst suppression avoidance? Because we still need to know more about that. So Engage's trial it's a single-center trial from WashU in 1232 patients, a mix of cardiac and non-cardiac patients, BIS-guided versus no BIS. They did not see any difference between EEG guided versus non-EEG guided. Again, this is not multimodal, but just EEG guided versus non-EEG guided. Balanced trial, recently published in Lancet, a subset of these patients, as you can see. In the next slide, yes, you can see that here they found that patients with lighter anesthetic actually had lesser chances of postoperative delirium than patients with higher anesthetic or increased depth of anesthetic. So in their per protocol analysis, not the intention to treat, but per protocol analysis, 17% in lighter anesthesia because BIS of 50, in deeper anesthesia BIS of 35, you had 29% incidence. So still conflicting evidence, Engage's trial and the subset of balanced trial. So some more work needs to be done. So what does the evidence tell us? It's not just about light versus deep anesthesia. Can we do something more than that, right? Like a EEG guided multimodal anesthesia, which really is coming close to the precision medicine. If only we add the pain monitors in the OR, it makes it even better. This has got a sound neurocircuit theory why multimodal analgesic approach is really beneficial. Emery Brown actually produces, is an eminent neuroscientist from MGH-MRT. The added advantage of doing this MMGA is, vasopressors and hypotension. So recently we published this in anesthesiology. It's coming it's already online, but it's coming in the real print, I think in June. You can see that patients with the highest degree of hypotension, that is the last quartile of the duration of hypotension in intraoperative period, in cardiac surgical patients, this red bar had increased incidence of acute kidney injury, stroke, and mortality. Actually, here you can see even in the vasopressors, if you adjust for a third and fourth piece, the third and fourth piece of vasopressors can be associated with intraoperative hypotension. Now, we can reduce the amount of vasopressors required in these patients if we give just the right amount of anesthetic. How many times you have turned on the gas and off for controlling the blood pressures instead of giving the right drugs, right? So if we can give the right depth of anesthesia, maybe there is a reduction in the amount of norepinephrine equivalents in the intraoperative period, and they may translate into reduced postoperative delirium. I would just say this, that while all this is being figured out, why not just give the right amount of anesthetic that a patient requires, and and also treat the blood pressures for whatever or not treat all blood pressure hypertensions as lighter anesthetic. Switch gears here and then move on to sleep. And what can we do about that? We all know that there is abnormal sleep pattern in the ICU. There's broken sleep. So what are the key features? Total sleep time and sleep efficiency are often normal, but there is sleep fragmentation in these patients, and there's lighter sleep. The deeper sleep, like M3 sleep and REM, are not probably as adequate as it should be. And there's a subjective reduction in the sleep quality. We still do not know whether there's a cause and effect relationships, and I'm eagerly waiting to see Dr. Keju's work from MGH, what that is going to show. Sleep measurements in ICU is challenging. And so, there's a disruption of circadian rhythm. So there is a problem. There's a bunch of problems with sleep. Can we do something about it, right? We also note that there is an association between sleep restriction and increased alpha TNF release and IL-6 release the same mediator is often blamed in the postoperative delirium. And here it's shown that low-dose nocturnal dexmedetomidine, if it is given, actually can help reduce the postoperative ICU delirium. Again, this work of giving one dose at 9 o'clock was finished recently by Dr. Akeju's group, and we're waiting to see the results. From our own lab, we are looking at orexin receptor antagonists like suvorexin and see whether enhancing the sleep postoperative daily night giving at 9 o'clock actually enhances the sleep and probably reduces postoperative delirium. We are halfway through. We'll complete it. It's a pretty complex study, but we're also measuring the EEG, etc. So the other half of the work will be done Montefiore under Dr. Eichelman's guidance. Let's look at non-pharmacological methods. There are guidelines that talks about sleep protocols, and we have always had HELP protocol right from late 90s. But there seems to be some problem. Not all components are actually done. ICUs have done a tremendous amount of work by providing real good options. So what is sleep hygiene, right? Follow a regular sleep schedule before you come for surgery, both from National Institute of Aging and also our own Sadhguru Center for Consciousness, Compassion, and Cognition. I think combining these, avoiding napping in the late afternoon or evening, not just for elderly, but even for us. These are all good sleep hygiene protocols. And before you go to sleep, keep everything aside that you gathered, your belongings, your relationship, your body, the content of your mind, your identifications. Just sleep is life. If you sleep in that condition, you'll wake up with much more energy and possibilities. Develop a bedtime routine. Relax before bedtime. Read a book. No television, no electronics. A comfortable bedroom temperature. Low lighting in the evenings. Exercise regularly, but not within 3 hours of your bedtime. Stay away from late caffeine. Remember, alcohol won't help you sleep. Even small amounts makes it harder to stay asleep. And importantly, wake up with a smile. So establishing this routine before you even come to the hospital for the surgery, provided you have adequate time to have this rehabilitation process, and in the ICU, establishing the day-night protocols, closing the curtains, not disturbing the patient, reducing the noise, all that helps. And hopefully everything is being done rigorously as much as possible. This is a good segue for prehabilitation. This paper from Nature talks about enhancing the cognitive reserve by doing whatever you need to do. So if you can enhance the reserve, that probably puts you at a better position to take a hit during the surgery, and maybe you won't dip down too much like that in your typical state. If you're ideally enhanced, you don't dip down below that orange line. Our own work led by Dr. O'Gara was the prevention of early postoperative cognitive decline. We had problems in compliance. Not everybody really did this lumosity training in the preoperative period to increase the reserve, but proof of concept, it is possible to enhance the reserve by using these lumosity measures. It to be done and shown that this is effective and can be done well. But another group led by Michelle Hamedan from OSU, Ohio State University, actually showed using the same modality in their per protocol analysis, they found a difference between the intervention and the control group. You can see that delirium was decreased in the intervention group with cognitive preoperative training. So with lumosity, it's possible that any kind of cognitive rehabilitation can help increase the reserve and put them at a lower risk for perioperative injury. Basis of cognitive rehabilitation through meditation. This is the second way you can rehabilitate. You can see that majority of these older patients actually have low intraoperative alpha band power, as shown by Patrick Perdon and Dr. Emmett Brown's group. And recently, they've also shown that acute breakdown in brain network connectivity happens in the intraoperative period. Elderly patients have cortical atrophy, and there is decreased BDNF and post-op delirium in these patients. And improved preoperative cognitive function happens with meditation. BDNF increases with meditation. Reduction of the cortical atrophy by Sarah Lazar's group. Enhanced brain network connectivity, and is enhanced alpha band power. Seems like all these can be countered with regular meditation schedule in the preoperative period. Only thing, you need to do it regularly, and you need to have at least 3 to 4 weeks in the preoperative period Often that time is not available, at least for cardiac patients. Maybe for joint patients, it is available. So we just talked about what all meditation does. It also helps sleep. It increases higher melatonin levels. It is the only thing that mimics natural sleep. Among the drugs, dexmedetomidine comes close to mimicking natural sleep, with its oral form coming very quickly in the market. Hopefully, that can also help solve this problem. And this was the work that I mentioned about the reduction in the alpha band and the old age. So with that, I'd like to point out that sleep can be reversed or at least enhanced with the meditation in the preoperative period and in the intraoperative period. If patients have the ability, can follow certain sleep hygiene, whatever is possible within the limitations of the ICU and the post-cardiac surgical environment or any other post-operative environment. And we also need to do cognitive rehabilitation using techniques like, lumosity or meditation or anything else that can. And absolutely take care of pain. So probably that all these three together can act as real bundle to reduce post-operative delirium. And it is important to focus on all aspects, not on just one aspect, to give the best possible experience for the patients. I'm very thankful to my entire team in our Sadhguru Center for a Conscious Planet, which we started in November 2020. And we are focused on enhancing consciousness, cognition, and compassion. And all of them have been tremendous in our work that has been ongoing. In the cognitive research, we are very grateful for Dr. Mark Antonio's group, Brian O'Gara, and Somnath Bose, Tovia Lieberman from System Biology, Hassan Otu, and our own postdocs, statisticians, Michelle from OSU, the cardiac anesthesia group, cardiac surgery group, ICU nurses, pre-op testing clinic, and my consciousness scientific guru, who's Emily Brown, and my consciousness master, who's Sadhguru. Thank you so much for this opportunity, and I hope you look at sleep, cognition, and pain, three important intervenable opportunities in the perioperative period to reduce the perioperative neurocognitive decline. Thank you, and have a wonderful day.